On behalf of the All Ireland Institute of Hospice and Palliative Care, I am delighted to welcome you this evening to this public webinar on an important piece of research that we supported called Shaping Palliative Care Policy using a human rights-based approach. And it was looking at examining the experiences of nursing homes and residents, families, and staff during the COVID-19 pandemic. So this piece of research was funded by the Irish Human Rights and Equality Commission, and it was carried out by the University of Limerick on behalf of the All Ireland Institute of Hospice and Palliative Care. And my name is Mary Rabbit, and I'm the Research Programme Manager with the Institute. We would like to acknowledge the support of our other consortium members who were involved in this study, including specifically the HSE, Nursing Homes Ireland, the Irish Hospice Foundation, St. Vincent's University Hospital, Tallaght University Hospital, the Decision Support Service, and members of the Institute's Voices for Care group. So I'd like to now introduce you to our speakers this evening. We will first hear from Dr. John Lombard. He is a senior lecturer in the School of Law in the University of Limerick, and he is recently the author of Law, Palliative Care and Dying. And also along with his colleague, Dr. Owen Doody, who is a registered intellectual disability nurse, as well as being a senior lecturer in the Department of Nursing and Midwifery. And he is also co-author of Nursing and Healthcare Ethics. So we're delighted to welcome you both this evening and looking forward to the presentation.
Thank you very much, Mary, for that introduction. So as mentioned, my name is John Lombard. I'm a lecturer in the School of Law in the University of Limerick, and I'm joined this evening by my colleague, Dr. Owen Doody of the Department of Nursing and Midwifery, also from UL. Before I get started on the presentation, I would like to thank all the groups and individuals who supported this project from its inception. So during very challenging and difficult circumstances, people found time to contribute in a variety of ways. The support of the various stakeholders was essential to conducting this research and capturing the lived experience during COVID-19. We would also like to acknowledge and thank the Irish Human Rights and Equality Commission for providing the funding to support this research through the Irish Human Rights and Equality Grant Scheme from 2020 to 21. Mary has set out the title of the research project, and it's also in the introduction. And as part of this, there were two strands to the research. The first was a policy analysis component, and the second was a questionnaire component, which attempted to capture the experience of people living in nursing homes, their families and staff during the COVID-19 pandemic. So in looking at what it is that we're going to talk about this evening, you can see that the key points set out on the current slide. For my part, I will discuss the project background, aims and objectives, and some points relating to policy and guidance documents. And at that point, I'll hand over to Dr. Owen Doody, who will speak to the survey data and the recommendations. So in looking at the background to the research project, you can see the current slide provides a broad timeline of the early development of COVID-19. And I think timelines like this are useful to remind us about the pace of change and to underline how our knowledge of COVID-19 was developing. I think it can be all too easy to look back and to assume that the level of understanding was far greater than it actually was. And I think there are certainly dangers with that type of hindsight. So in looking at some of the key early points around COVID-19, we know COVID-19 emerged in Wuhan back in December of 2019. The scale and severity of the outbreak was underlined by the World World Health Organization, when on the 30th of January 2020, it was declared a public health emergency of international concern. The first case of COVID-19 in Ireland was confirmed on the 29th of February, and on the 11th of March 2020, it was declared a pandemic. Restrictions were then announced in Ireland the following day, and this included the closure of schools and limits being placed on mass gatherings. The first confirmed case of COVID-19 in an Irish nursing home was on the 13th of March, and by the end of March, it was clear that COVID-19 infection had taken a substantial hold in long-term residential care, with little over 20% of clusters or outbreaks reported as occurring in that particular setting. So why did we concentrate on residential care settings for this research? And there was a number of reasons for this. So across nations, the residential care sector was at the centre of some of the most difficult experiences relating to COVID-19. People in residential care settings have been recognised as being highly susceptible to COVID-19 infection and subsequent severe adverse health outcomes. And this vulnerability has been linked to resident characteristics such as older age, a high prevalence of underlying medical conditions, and a need for high care support that is provided in these type of high physical contact environments. And a detailed list of these characteristics was eventually set out in a NEFIT paper in May of 2020. And by that time, May of 2020, in Europe, an estimated 37 to 66% of COVID-19 deaths had occurred in nursing homes. So in an attempt to control the spread of COVID-19 in these settings, a wide range of measures were introduced and were introduced in this jurisdiction. So for instance, early on the 6th of March 2020, we saw Nursing Homes Ireland moving to restrict nursing home visits, and this was expanded to HSE operated nursing homes from the 13th of March. And these restrictions varied over time, including the likes of scheduled visits, the limiting the time of visits, the use of window and remote contact. So nursing homes were under immense pressure at this time, while also needing to respond to an ever-evolving regulatory landscape. So around the middle of 2020, we felt there were important issues with a clear human rights dimension to be examined here. And as a result, we applied for the Irish Human Rights and Equality Commission funding to support this research project. So what was it we decided to do? So the research application was led by the All-Ireland Institute of Hospice and Palliative Care with Dr. Owen Doody and myself, named as co-applicants, and funding was awarded in October of 2020. As part of this, there were a number of project objectives, and you can see these listed on the current slide. So for instance, we set out to identify the needs and perspectives of people living in nursing homes, their families and staff on the care provided during COVID-19 by way of a survey. We sought to analyse the existing standards and policies for public and private nursing homes from a human rights perspective, and using this information and drawing on the information collected through the survey. The third element, or the third objective, was to promote the research findings with events for people and organisations with an interest in palliative care at conferences, through research publications, and through seminars such as this. As Mary mentioned, a wide range of partner organisations were brought together to advise and to facilitate the research project. You can see the various logos of these organisations listed on the current slide. And of these, Nursing Homes Ireland and the Health Service Executive acted as gatekeepers in participant recruitment. All groups assisted in questionnaire development, providing feedback on the report and so forth. And again, it's an opportunity to thank everyone for their comments and feedback at various points. So in looking then at the body of the report, section 2 of the report outlines the human rights framework in Ireland. This included discussion of state duties and responsibilities during a pandemic, as well as setting out human rights in healthcare. The section identified and outlined several human rights of particular relevance to our research. This included the right to life, the right to be free from inhuman or degrading treatment, the right to private and family life, along with the prohibition on discrimination. And these rights were factored in as part of later analysis and discussion within the report. In looking then at the policy analysis component, so detailed analysis of the policy and guidelines was originally planned, but this needed to change by the time that we were over a year into the pandemic. What was originally set out was no longer feasible given the scale and revision of policy documents, as well as the reordering of the research timeline. Instead, the policy analysis component served to provide context for the survey data. In identifying the relevant policies, we searched several websites, as you can see listed on the current slide, including the Health Protection Surveillance Centre website, HSE, HIQA, and the National Healthcare Service Library website. As of November 2021, we were able to identify 33 distinct policy and guidance documents. And it's important to note that this excludes previous documents or previous document revisions, of which there would have been a multiple number of documents identified. Policies addressed vaccination, healthcare needs, infection control, end-of-life matters, ethical considerations, visitation, and day services. And of the various policy areas, the final report concentrates on visitors and visitation, palliative care, and ethical guidance, thereby providing that context for the later parts of the study. As part of this, the discussion teased out the role of law and human rights in informing and shaping policy and guidance documents. In relation to those ethical guidance documents that I mentioned, there were several of these documents which were published in response to COVID-19, but human rights were not always expressly to the fore, although a notable exception is listed on the slide, that being the ethical considerations relating to long-term residential care facilities in the context of COVID-19. This document also illustrated the unique position of nursing homes in that they were a residence as well as being a healthcare setting. In particular, there are specific ethical values that are at risk and need to be nurtured in these settings, namely protecting and preserving autonomy, dignity and privacy, as well as building and reciprocating trust and mutual respect. And these were among the themes that we sought to explore in the questionnaire component, which Dr. Doody will now set out.
Hey, good evening, everyone. Thank you, John, for the background and introduction to the project, and Mary. And picking up on from where John left off, we had developed the survey instrument and in conjunction with our partners, and the survey addressed questions in relation to the perspective of the residents, families, and staff. So a survey instrument was developed and agreed with stakeholders, and the wording then was altered to represent either resident, staff, or family member. And so 3 versions of the one survey. And it revolved around asking around 4 main sections. The first one being the resident experience, the second being the approach of the healthcare staff, and the third being the nursing homes service itself or environment, and then general demographic areas such as age and gender, how long they've been in the setting as well. So in order to circulate the survey, we had ethical approval from the Ethics Committee at the University of Limerick and the University Hospital Limerick Group. And that enabled us to go to the HSE sites and the Nursing Home Ireland sites with an overarching ethical approval from a university and a healthcare service provider. The option was to complete the survey online or in hard copy, or we could actually facilitate a face-to-face completion. And did utilize a user-friendly approach with the use of emoji, happy face signs, or for a level of agreement, to dissatisfied signs for a level of disagreement. So who participated in the study? It was circulated out through our networks. Sites were, nursing home sites were invited to participate, express an interest. Our collaborators, the AIIHPC and Nursing Homes Ireland, and the Ireland Institute made the survey accessible in online format as well to its networks. 118 people responded to the survey, of which 25 were residents, 42 were family carers, and 51 were nursing home staff themselves. And was predominantly female, 69.5%, and the remainder 30.5% male participants in the survey. So what do they say about the information provided about COVID-19 to them? And I suppose while I give some slides on findings here, I would just draw people's attention to go to the full report to get greater detail and the overall responses to the survey instrument and questions asked, and get, I suppose, a more in-depth picture or an overview picture of the survey itself and people's responses. So overall, information was provided, was clear and understandable. 99 participants indicated it was clear and understandable, while the other 16 indicated the information could have been clearer, I suppose, and more understandable or adapted to their needs. So generally, a high rate of success in relation to, I suppose, informing people and keeping people informed. In relation to the experience of residents, from residents and staff perspectives and families perspective, we asked a range of questions to the three groups in relation to what they perceived as the experience of the residents themselves, from feeling safe to being able to choose the activities, to feeling happy, feeling lonely, being worried or anxious or fearful, or being supported to be independent. And as you can see just from the slide itself, you can see generally all scored very well in the 70% aspect would be the aspect of feeling lonely, scoring pretty high in relation to people agreeing that they were, and I suppose it's reflective of the time. Family visits were curtailed, there was a fear, staff were busy, they were under-resourced, maybe due to sickness and leave, and I suppose that general aspect of loneliness was high in the responses, but I suppose it is offset in relation to nearly 60%, were generally feeling happy overall, over 50% felt safe and in their environment. So, so I think respondents were very clear and very fair in the responses, and gives us a clear overview of the feelings of the time, and that will be seen in other areas that are not presented here, that you can go to the report for at your own convenience. In relation to the nursing home environment itself, from the residents, staff and families' perspectives, this revolved around residents, I suppose, the aspect of choice, being able to go to bed and get up when they want, being able to choose who else was involved in their care. It's been supported, or being able to spend time doing things they enjoy, use of alternative communication to support engagement with family, and support and relevant information to make informed decisions, and residents being supported and given all relevant information around advanced care planning. And again, predominantly positive in the 50s range up to the 70s range. And I suppose of note, 70% were in agreement that they could spend time doing things that they enjoy. So while there was a lot of restraints and curtailment, there still was opportunities. And I suppose it's for us to learn from the pandemic and how we manage and what we prioritize, and how we prioritize people's rights and humanity in difficult times is important. In relation to the survey, we offered the opportunity for open text responses as well throughout the sections and at the overall end of the survey as well. And I suppose to acknowledge, this gave us rich data, and I suppose hopefully captures the experience. And tonight we just present some of the comments and we can reflect on those. But 6 residents responded, 12 family members, 18 staff to the open-ended. And while the evidence was overall positive in relation to the experience, there were, and especially around the efforts to maintain social interaction and contact, there were some negative comments, but I don't see them as negative. I see them as realistic and fair, and representing the feelings and emotions and the insecurities and the fears of the time. Some relatives reported poor communication. Not everywhere has internet connectivity, and something that even rural and urban areas were evident in. Not enough mobile phones or tablets, so the infrastructure not being available, but if it was available, then the resources to utilize that infrastructure in the form of tablets or mobile phones or other media devices. Also, sometimes people need support in order where there is connectivity and there is a tablet, but they're not familiar with using it. They need support and guidance in the use of it. And, there was an acknowledgement that staff were very busy and not always able to assist people or give the time when someone was looking for the time. And it might be not that it wasn't that it was not done, it was that it was offset to maybe a time that was convenient for staff versus this time that's convenient for resident. So the use of equipment and the availability of technology were 2 key factors, and something that is nationally needs to be addressed. In relation to the resident experience, and I suppose the voice of the residents, while we didn't have many respondents, only 6, their comments were very impactful and meaningful and reflective of their experience. And, I suppose to capture this, just taking one comment, it was hard when the masks and gowns came. It was difficult to know who was with you or even what they were saying. I often did not know what day it was, and as family were not calm, each day ran into each other, and I was getting more and more confused. And I suppose you can nearly see that as I read it, or as you look at it on screen, that how that realistically would impact upon a person residing in a nursing home, and how those feelings of loneliness, isolation, confusion, each day running into each other. And it wasn't for a week or a month. It was, COVID was for a long period of time, and I suppose people had to endure it, and some people had to endure it harder than others, or more than others. And I suppose that's more so than for a vulnerable group, be they in a care environment or in a nursing home. What did families say about care provided? Again, there were 15 family members and 5 staff that expressed comments here about care provided. From a family member perspective, their comments were, one of their comments were, they were in a safe, familiar place with caring staff who did their best in a terrible situation, and staff went above and beyond the duty of care. And I suppose that's very positive, and I did acknowledge earlier on that there was some negative comments, but I think family were very realistic and fair, that they, in relation to their comments, in relation to that, it was an onerous time, there was a burden, there was a demand on staff, but they did reflect that it does affect, and it did affect feelings and emotions and loneliness, and also the time spent with their family members and during this time. From a staff perspective, if COVID-19 infection did not end lives, then loneliness and heartbreak changed life trajectories. I suppose this quote kind of really reflects kind of our philosophy that we try to ensure, the person-centeredness, being reflective and engaging with the person, putting them at the core, at the center of their care. And I suppose this comment from staff reflects that, that no matter what was going on for them, that they could see the importance and the heartbreak and the loneliness and the change in the life trajectory for the people they were caring with and spending time with on a daily basis. So the challenge of maintaining appropriate staffing levels, was something that really came out in the research as well. And I suppose, that's reflected in the family members, in the demands and going above and beyond the duty, because they could see that staff stayed away from their families for periods of time. Some even stayed in the nursing home itself or nearby accommodation. So there was sacrifices made, but we have to learn from those and how we can change, if there is future pandemics or epidemics as we go forward, or other situations, even just general infection control, how we manage and how we limit and how it may impact upon people's rights and choices. So what did families and staff say about the experience of care? Again, there were 12 family members who provided comments and 5 staff here. And from a staff perspective, prior to COVID, there was no PPE and no real engagement with nursing homes. Whereas now we are in the news and under the spotlight, and resources like PPE are coming, and it begs us to think, why is it only because of COVID? And I suppose, it's questioning going forward. We maybe should have always had these resources, PPE, equipment, infection control principles and actions, and maybe they need to be properly resourced and not just in times of COVID. For our family member, I did not understand what was happening and I could not be with them. It's sad for them to be alone at the end. It's just not right. I suppose, this is referring to the family member who had actually lost a resident family member of theirs during COVID. And they were still battling and trying to understand why this happened, why they couldn't be present, while you try to rationalize it. And I suppose, just anecdotally, I was talking to a person there recently and working in a nursing home, and they said, if we were to go through this again, I don't know, would I adhere to some of the guidance that were there, keeping families apart from their loved one. Is it right? They're beginning to ask those questions. So they're the challenges for us going forward. And, using what we've gathered and the information that we've gathered and the learning and understanding that we can create from that for plan for the future. Another staff member, we worked around the clock to help and keep residents safe during the pandemic and worked tirelessly in care and support. It will mean a lot to staff to get some recognition for all the sacrifices that we made and with not seeing our families for a long time. So I suppose I said it already that some staff stayed in the nursing home or nearby accommodation to minimize the risk for residents. And that called for sacrifice. And it's not just nursing home staff, it was paramedics, it was nurses, it was doctors in other care settings as well. And I suppose that sacrifice it shouldn't go unrecognized and unrecognized and unacknowledged as we go forward in the future. So there's a snapshot of the overall kind of taking some of the findings, but as I said, the report highlights are in greater detail more and all for each section. In relation to the recommendations, I'll hand over to John for the first part of the recommendations because they're more around the policy in the human rights area, and I'll come back then to the second slide, the recommendations for myself.
Thanks, Owen. So unsurprisingly, several of the recommendations that the report makes related to the role of human rights and the importance of actively taking account of human rights when developing policy and providing care. For instance, the report sets out recommendations such as that respect for human rights should inform and shape the development of national public health guidance and policy, and that national public health advisory groups should include persons with expertise in human rights and equality. So these two recommendations tend to be are relatively closely linked. The third recommendation then provides that the experience of nursing home residents, their families, and staff must inform the development of future epidemic and pandemic planning documents. In this way, the lessons learned can change future policies and practice, thereby ensuring that human rights can be best protected into the future. So passing back to Owen now.
Yeah, and from a care perspective and a healthcare service perspective, I suppose it's important from the evidence we gathered that palliative care should have a more central role in the national epidemic and pandemic planning process to encourage a more complete response to infectious disease and control. And with that in mind, and the recommendations from John around the human rights, it allows us to, discuss and plan for how we're going to deal with human rights, how we're going to deal with visiting, and what is right and appropriate. And I suppose emergency measures are emergency measures, but what we can learn from them going forward. Also, a focus on strengthening nursing home care and supports, communication plans and tools and resources is needed. So I suppose, one of the things that John highlighted earlier on was that documents or resources or policies were changing continuously, and that was in reaction over a short period of time. And he mentioned 33 reports, but there was over 130 reports at different time, or guidance documents that were infiltrated into the care system that people had to sift through, had to plan for, had to react to and respond to. And sometimes communication pathways, communication systems can fall, and one's reaction to a new guidance document can be delayed. So there needs to be a look at how we look at communication and communication strategies, how we support the resources such as the PPE that I mentioned earlier on, and how we acknowledge the infrastructure around internet accessibility, usage, and ability of then the user itself, end user itself. And finally, from a nursing home perspective, I suppose individual nursing homes should have greater support in applying policy at a local level. It's great to have national guidance and national documents, but for it to filter down to the front line where the person is going to be in receipt of service is important, and how we manage that and support that is going to be key, and that needs to be a key learning from the overall pandemic and epidemic itself. And hopefully we won't be escalating as we move into the flu season in October again, and that we've I suppose had the opportunity to learn and change our practices and hopefully minimize the spread of COVID in the coming winter season as well. So I'll hand over to Mary now, who will just give an infographic representation of the research project itself, and remind people to refer to the report, as Mary will highlight as well.
Thank you, Owen, and thank you, John, for a very informative presentation of the results and the recommendations. And as they mentioned, you can find more information and the specific details, and the QR code is there in the final report, which is published on the palliativehubprofessional.com. We've been recording the session today, and we'll also make that available on the Palliative Hub. And we'd just like to thank you for attending today on behalf of the All Ireland Institute of Hospice and Palliative Care. This webinar, which has been part of the loads of different events for Palliative Care Week. And my colleague Paula Pinto is on the line as well, who has been key in organising what has been a very successful week for us. So please follow us on Twitter, social media, in the news and media, and please spread the word about palliative care. So thank you very much, and I hope you have a lovely evening. Good night.